hard to follow a practice-changing PROC trial. But I'm going to try, okay? So, and why did we give that 20 minutes for one trial when we gave 20 minutes for all the platinum resistances for that? We wanted to discuss where's the sequencing. We're going to get into that a little bit more. So where are we going? So we're going to talk a little bit beyond MRF, okay? Targeted replication stress, immune therapies, some updates on the NCCN, some future direction. Then we're going to change gears a little bit and do a couple of low-grade trials that we saw with very exciting results. So, luvolumab tazevibulin. I think I actually did that pretty well.
You got to practice more, Dave.
No, that was good. Lavaltamab. That's what I said. Okay. This is also anti-folate receptor alpha, also with a, we used to call it STRO-002. And this was presented by Anna Oken, and Wendell Naumann, really in the US, has led this development. Again, folate receptor alpha, once again with an antimicrotubulin from a payload. And what this was really was a dose optimization, dose finding, as well as a trial looking at the biomarker, because we need to go beyond folate receptor alpha, which is high, which is about 35% plus or minus of our high-grade ovarian cancer patients. And so there are many opportunities to continue to develop folate receptor alpha antibody-drug conjugates. As we looked at the results here, the lighter blue was the 4.3 dose, the darker blue is 5.2, and on the right there you see that yellow, which is at the bottom of the waterfall and to the left of the swimmer lanes plot. That's looking at the biomarker, which in this case was a TPS score for folate receptor. Those that were greater than 25%, and those that were less than or equal to 25%, which in this case, you see the lighter yellow. What's really interesting here is you see a very impressive waterfall plot with overall unselected population of response rates of 32%, but in those with at least 25% expression, went up to about 38%. And at the very bottom, we see that represented, and in the middle there, in a TPS less than 25, we still saw 11% response rates, but in that middle range, about 33, and a slight uptick, small numbers here, we saw a 40% response rate. So looking at the number of patients, 9, 12, and 20 in that middle group. And as we look at the overall dose intensity, taking those patients that had greater than 25% expression, you see a slight increase in the response rate, 30 versus 44, and again, very small numbers. So, does come with some toxicities with all antibody drug conjugates. My patients say, well, is this chemotherapy? This is chemo. This is directed chemo, but this is chemo, okay? And we see here, and I've highlighted some of the more common, is neutropenia, which we actually saw about 4% febrile neutropenia in both doses, 4.3 and 5.2. We also see some GI, as well as arthralgias, and actually going up to grade 3, 26% in that middle group, in the lower, and about 10%, ironically, a little bit lower in the 5.2 dose. So we are seeing different toxicities. We don't see eye toxicities. But we do see other toxicities here. And so that trial actually has led to the development of Refrain, which is a large phase 2 into a phase 3 trial, which would be both an accelerated approval pathway as well as a confirmatory trial all in one as we move forward, as well as a dose optimization strategy. So we've already seen the Destiny pan-tumor 2, and I want to draw your attention to the far right. We saw the endometrial, but here in the ovary, 40 patients in the ovary, 45% overall response rate, 10% complete responses, okay? Now, we don't have the details to these patients, so we'll wait to get more data. And the far right of the graph, of the bar graph, we see in the middle green here, 3+ IHC actually at 64%, very small numbers. IHC 2 plus 36, and overall 45%, which includes 0 and 1. Again, the central testing. Now, we're excited about this. This is a cool drug. For those who've given it, it's an active agent, and we need to get this to our patients. what we were talking about, and Tom Herzog is going to discuss Duo and our impressions on that. But I have to remind everybody that Mediola, which looked at the combination, the triplet combination in platinum-sensitive treatment, had an 88% response rate. We did not see that quite translate into Duo. So again, more data is needed on this, but clearly a very exciting agent for our patients beyond MERV. And this is just the waterfall plot, seeing almost all patients getting clinical benefit from this agent. But against it, again, toxicities. We have nausea, fatigue, some grade 3, as well as neutropenia, usually manageable, usually not complicated. So the GI with diarrhea, nausea, vomiting, utilizing prophylactic measures can help in this, but obviously, again, this is, though an antibody-drug conjugate is a chemotherapy. And how about targeting and replication stress? Well, Panos presented his follow-up to the Gemzar berzosertib. I practiced that. That didn't go well. But berzosertib, that he's looking at this trial that's originally presented the weekly Gem plus or minus the ATR inhibitor. And when we looked at this as well as the biomarker status, the overall survival when removing the crossover patients, which were 42% of the patients, you see a hypothesis generating separation between those curves in the combination. Again, a group of patients that we're very excited about, or a group of agents, I should say, we're very excited about. And then in an exploratory pre-planned analysis, he looked at those that had replication stress high, which were none of the not having the RB1, NF1, and those listed there, as well as not having CCNE1, KRAS, ERBB2, and MYC. So those that were considered, if you did not have that, then you're having high. This was a little bit surprising to me, and I really want to hear what Katie Morris says. She's spent her most recent career studying on this. But those with replication stress high, again, small numbers, that the single agent gemcitabine was enough, and actually the combination did not add in those patients. Again, small numbers separating that you did not need the ATR inhibitor, and actually those patients did worse. WEE1 inhibitors, we've been very excited. We've been studying this. I think I heard Brad say, his first trial with the WEE1 inhibitors 10 years ago. Right. And we haven't seen these come into development, but now we're starting to get excited. Azernasertib is a WEE1 inhibitor. Looking at this and reported, this is actually, we have 4 trials open in GOG Partners with regards to this agent. Again, WEE1 inhibitor. What was presented is their phase 1 data. Look at the combinations on the bottom, they're listed here. So I just want to draw your attention, reading left to right. The overall response rate with weekly paclitaxel plus azernasertib was 50%. We'd expect about 30% here, about 30%, okay? Plus carboplatin in a platinum-resistant population, the response rate was about 36%. Unclear what we'd expect here. Gemcitabine, 39%. You'd expect this to be near single digits, 10% or less. And PLD, again, 20%, you'd expect this to be somewhere in that 10 to 13% range. So at the overall population, we had 34% response rate. So clear activity, and now we're figuring out the dose, and this most likely will move into a larger phase 3 trial that it continues to be undergo design changes. And how about immune therapy? Well, I saved this one for last because this is a large phase 3, VBL111. We really had a lot of, we really thought this was going to be positive. That's about as wildly negative as you can get, right? So Becca Aaron and Richard Penson led the development here in the US. We had an interim analysis that looked very convincing. And you see some separation in the curves there at 4 to 5 months. Unfortunately, the separation of the curves favored weekly paclitaxel. So looking at the far right here, we got overall response rate, unbelievably consistent in our platinum-resistant population. Weekly paclitaxel response rate, by far our best combination outside of platinum doublets, 30%. there was no difference with the addition. So unfortunately, development of this agent is not going forward.
Can you stay on this slide for a second? So weekly paclitaxel has a response rate of 30% in this trial, in both arms. What about in the Aurelia trial when you evaluated the weekly paclitaxel with bevacizumab arm? What was the objective response rate there?
So weekly paclitaxel by itself, right at 30%. You add bev, it goes about 54%.
So I'm just going to throw this out to Bhavana in terms of evaluating all those novel agents that Dave just talked about and the ADCs, including MIRV and the ADCs beyond MIRV. How are you going to decide how to treat your patients? Is it a weekly paclitaxel plus bev approach or an ADC approach, and which of the ADCs? I'm projecting into the future here.
Yeah, I think, you know, the Mirasol data and, I mean, Katie's data is so impressive that I think with an overall survival benefit, I would move it, you know, above weekly Taxol and bevacizumab. That's the only study that's shown a survival benefit in platinum-resistant ovarian cancer. So that would be my approach.
All right, great. I want to just get that question there. And then, Dave, I know you have a few more slides to share with us.
Yeah, so, you know, it was interesting. I put this up because I wanted to highlight there's some pretty marked changes in our NCCN guidelines. I did not include the preferred regimens because that didn't catch me by surprise. With regards to the preferred regimens now include MIRV, they'll be updated again with Mirasol. But what we did is that when we saw the ESMO guidelines with regards to not eligible for platinum, it really forced us to look at our treatment paradigm for platinum agents if they weren't primary platinum resistance. If somebody has a complete response to platinum in the second line, not to go back to that just didn't seem right. But they weren't listed. The platinum and platinum doublets were not listed in the NCCN, which actually got us at times concerned because when we're designing clinical trials that offer that option, it was a challenge. We actually have a phase 3 trial on Prime, which is looking at their bio vaccine combined with carboplatin paclitaxel in a platinum-resistant, even refractory patient population. And Rob Holloway presented that at IGCS last year, and the data is really, really impressive. I wrote down here, 54% response rate. So what else? You know, Dr. Santine from Yale, Alessandro presented the ixabethalone bev, I think also at IGCS. Once again, seeing a response rate of 33%. So agents that both of these kind of caught me a little bit by surprise, though I used the regimens, but it's nice to see those listed in the NCCN guidelines. So where are we in the NRG and GOG? Okay, Rosella 3073, there's relacorilant with nab-paclitaxel. Alex Laway is leading this trial. Any patient that you think is eligible for weekly taxanes, that's a great option for you. Tom Herzog, Profecta, AKT inhibitor. Gosh, we only have about 8 more patients to enroll in that trial. Let's push that across the finish line. We talked about Sutro and its final development, 3086. And then we have the IO therapies. Really, really exciting agents that we're developing here. We've already talked about some of those. We also see Supras-3, our first kind of CAR-T type directed therapy here. So I would challenge you all. I've heard, well, I can only have one platinum-resistant ovarian cancer trial. We obviously can have more than that in our portfolio. We continue to target DDR and maybe PARP resistance. We're going to really say DDR. And we have essentially 7 trials. Well, I guess I can take oval off this now. We know it's negative. 6 trials, which we are going to read out. Tumor Treating Fields. I don't know if you saw the LUNAR study at ASCO. Positive overall survival in non-small cell lung on the Tumor Treating Fields. Okay? We should see that readout shortly, accelerate the work by Catherine Fa in the AirVive. And so obviously we've heard about Mirasol, look forward to Uplift, and as well as our NRG. So lots going on that could potentially change the landscape of platinum-resistant ovarian cancer.
Can you go back to your last slide?
Absolutely.
Okay, so really impressive portfolio. I think you had like 2 or 3 slides in terms of the portfolio at GOG. So Brian, at your center, and you're trying to make decisions about what to open for your research studies, how are you doing this? How are you deciding between all these studies?
Yeah, that's a great question. I think it's multifactorial. One is a priority is always to have one open, at least. So in that respect, I have one open that has a decent amount, like, if it has 8 patients left, then I'm not doing my job. I want to make sure that there's a second one open. The second is to have at least one open, at least 1 or 2 in the pipelines that'll open in the near future, which is important. A factor is when these trials are open to site selection, because we can't always, sometimes there's an interesting trial that comes out, but I recently opened one, and last but certainly not least is scientific interest. Now, I know that all these trials are worthy of getting further investigated. However, in certain areas or by certain investigator preferences, that'll play a role. Right now, I have the Rosella trial open, which is a really nice trial, and we're screening a couple of patients there. And I have the GEO 30081, those trial, I don't think it has a name yet, sponsored by Acrivon trials open.
Yeah, thank you. That's really good advice. And anybody who's interested in these trials, just let Dave know. You know, while we've made great gains with mirvetuximab, and it's certainly very exciting, I'm certain there will be some patients that will still progress. So we need to be ready with the next iteration of clinical trials. All right, Dave, go for it because you have low-grade serous. Oh, Bhavana.
I just wanted to add one point to that. I just think it's, when we're treating platinum-resistant disease, I think it's really important to have multiple trials open, and where you can kind of sequence them from one to the next. For instance, I usually have 4 to 5 platinum-resistant trials open at any given time. So I think just being thoughtful of that as you're thinking about your patients and how to sequence those.
You actually need to, too, because some of the trials are Bev agnostic, others require prior Bev, some of them, by lines of therapy. So I think in order to not let patients fall between the cracks in terms of the opportunity for a clinical trial, you need to have several open.
I'm going to go to Brad and then back to you, Brian.
So Dave, I'm looking at your portfolio. Congrats, our portfolio. I'm still trying to unpack Mirasol as great as I think it is. What do I mean? Well, it showed a 1.6-month improvement in progression-free survival. I know it's a hazard ratio, Ramez, 0.65. Still 1.6 month. And I know that the hazard ratio was similar for overall survival, but a 3.7-month improvement in overall survival. Is that the expectation if we're going to get a positive trial, that the hazard ratio for PFS is going to translate over to the hazard ratio of OS, which is going to mean that the medians are going to be greater? Is that sort of the way this works, or is this something that was unique to Mirv? And certainly Katie and you can answer both together.
Hey, Dave, I think we have to hold on here. We need to preserve this moment for history, because I remember so many times Brad telling me it's not about the median number. It's not I just want to preserve that moment. But go ahead, Dave, answer the question.
No,
and then we'll go to Kate.
I think we need Rob Coleman to, to give us that our statistics talk.
Lesson.
So, I think that's a very complicated question that you had about 3 questions in one. First of all, your last question, which is, can we expect that translation to improve upon on our survival? Yes. This is not the usual. We do not see that the hazard ratio is consistent or improved upon OS survival.
Right.
Okay? But let me go back to, I think, the most important aspect of the question. Should we be settled here? Should we go, okay, we got one drug approved, we're done. Okay? Weekly paclitaxel, 30% response rate, single agent. Very, very consistent across trials, to include phase 3 trials. Everything else in the contemporary, PLD, gemcitabine, topo, single agents, maybe 13%. Maybe 13, but really single agent. Now we have 42% with Mirasol in 35% of our platinum-resistant patients. Not only are there opportunities to improve upon this, there's absolute 100% need to improve upon this. All of our patients who recur, and we're curing more patients, will ultimately become platinum resistant. We absolutely have a responsibility to identify more targets and more agents.
So I want to give you a chance to talk about low-grade serous cancer, and I also want Katie to have an opportunity to address some questions about low-grade serous, and you have 36 seconds left.
No, I don't, because we are running way ahead, and they put the timer 5 minutes short, so we actually have 5 minutes.
Okay,
but
that's perfect.
all right, but you're moderating. Okay, here we go.
Let's go.
All right. So, on a serious note, that we did allow more time for this section. So, from a low-grade standpoint, as much as I hate to admit it, my friend Brian did well. Dr. Slomovitz presented 3026. We're like brothers. So this was presented at SGO, and I in the opening plenary. But it really, when you first see this, and you don't see that many low grades, it didn't really sink into for me. I knew I saw activity. I participated in this trial. We saw a 23% response rate. Okay, 23% response rate. But look at the bottom right. You see prolonged disease control. But a very important point, the median time to response was 8 months. These CD46K inhibitors with AIs in low-grade cancers, you don't see tumors melt away. And you have to follow them for months and educate patients that disease control is obviously very important. What else? They get very excited about having a pill, like we've saw with PARPs and everything else. Looking at the toxicities related to the hematologic toxicities, as well as some of the other fatigue in GI. So very important from that response rate is 23%, but disease control and prolonged disease control was very important. Which leads me to GOG 3052, or RAMP 201, one of the more exciting trials and reports that we saw here at ASCO. Okay, so this is it was a 2-arm trial, and it really because of the 4-arm trials you see there, which looked at patients who were KRAS mutant versus KRAS wild type, but also the single agent of the RAF/MEK inhibitor versus the combination with the FAK inhibitor, okay? And so the FAK inhibitor bringing in was thought to block the mechanisms of resistance to the RAF/MEK inhibitor. Both oral agents, a little bit funky on the on dosing, but actually pretty well tolerated. We'll talk about it in a second here. What did we see? Almost everybody responded in both arms. The waterfall plots here are unbelievably impressive. But look at the single agent versus the combination. We look at the response rate in the bottom left table. 45% response rate in the combination versus 10% in the single agent. So you saw disease regression with the single agent, but you just did not see that depth of the response. And it did come with some toxicities. For those who treat patients, we saw a lot of CPK, GI. We also saw peripheral edema, skin problems. But saying that, you're able to get the patients through, and we didn't have that many patients stop on treatment. This has led to the additional patients being enrolled, which you may have missed it, open and close so quickly to expand upon all comers in the combination. So no longer biomarking selecting. All patients were allowed to come on, and it was in the combination. They're now going to continue to optimize the dose and move forward with regards to a larger phase 3 confirmatory trial, they've said publicly. So all over the place here, but I wanted to spend some time on low grade because this is really exciting stuff.
Yeah, no, that was really great, Dave, and thanks for letting me interject some of my questions between your slides. So I wanted to talk a little bit more about the treatment paradigm in low-grade serous ovarian cancer, and turn to Katie here and just see what your thoughts are in terms of the treatment landscape and this drug combination as well as other therapies on the horizon like CDK inhibitors.
I mean, I think that the treatment landscape in low grade is finally getting some attention, not dissimilar to endometrial cancer, which is nice. This is a very small subset, but as we know, they live a long time, and so we actually need to be developing new therapeutics for them that are different than high grade. It's a completely different disease. So I think that Brian's work at SGO was very important. The manuscript will be very important because it's not easy to get CDK4/6s. Used to be easy. Not easy anymore to get it off label, and so this will hopefully allow us to access this combination therapy for patients. I think the unanswered questions with that study is that many patients now are receiving AI in the front line, and so is this as effective in that setting, or do we need to change to a SERD with the CDK4/6, and so that's one of the questions I think we need to think about. Other provocative data that has been presented comes out of MD Anderson, where they've done the neoadjuvant study of CDK4/6 with SERD, with responses that allowed patients to get to the operating room. But again, to Dave's point, it took a long time. Like, the responses don't happen by cycle 3, and so our endpoints are gonna really need to change. So I think it's an exciting time to really rethink the paradigm for low grade, from surgical expectations to frontline therapy on down. And some of these studies will, I think, be very impactful there. The RAMP study is probably the most provocative data we have to date, with RAF, MEK, FAK inhibition, and very high response rates, irrespective of biomarker, importantly. It was thought to be a KRAS opportunity. It's clearly more KRAS than mutated than wild type, but it's both appear to do significantly better than standard medicines. And so that's moving into a registration enabling study that, again, is exciting, but will take us a long time to do. And so that's frustrating that we can't like move it a little bit faster. But that may be a frontline opportunity. You know, one of the things that I'm really interested to hear your thoughts is, I feel like more patients get neoadjuvant in general, but including low grade, and then they never get to OR.
Yeah.
And then you just inherit them, and they're just full of tumor that's calcified, and you just keep treating this calcified tumor for forever. And so if we could use CDK4/6 up front with either a SERD or AI, or we use RAMP up front, we get responses, they get to the OR, maybe the goal is 90%, maybe it's not no gross here, and you help someone live longer and better. I think we just need to rethink low grade. And we're finally doing trials that actually will help us make good decisions rather than making things up, which is kind of what we do now.
You know, Brian, I mean, this is one of your lifelong passions. I mean, what do you think?
Yeah, no, it's a great point. I think we have to sort of make it very, very simple. And I agree with everything Dr. Moore said. Low-grade serous ovarian cancer is breast cancer of the ovary as far as treatment options. Because we've all seen patients come in with failed carboplatin paclitaxel, failed Doxil, failed Gemzar, and you never want to say people are treated incorrectly, but there's an area of opportunity there. We've learned with not only hormonal therapy, a lot of this work is based out of what Dave Gershon did down at MD Anderson, but hormonal therapy, we learned from trametinib, getting an NCCN listing, now from CDK4/6 and some of the data like the RAMP trial. So slow indolent course, hormonal receptor positive. These patients don't necessarily have to die from their disease, or at least not quickly, and we need to really focus on the clinical trials because it's an unusual time that we have so many trials, and we really need to enroll these patients onto these trials.
I want to go back to something that Katie said, and then I'm going to go to you, Tom. She had mentioned that CDK4 and 6 inhibitors used to be easy to get. So there used to be 3 drugs. It was abemaciclib, palbociclib, and ribociclib. And right now, the only one that we can get at our site is ribociclib. So Tom, I just wanted to throw this out to you. Are you experiencing that kind of similar issue at your place as well?
Yeah, that's an issue. And I was going to go back to Brian on a question of what's the role of chemo with an advanced low-grade serous? What are you doing for your next patient that comes in?
You know, so right now it's part of the NCCN guidelines, and that's really our treatment opportunity. Chemotherapy response rate is a fraction of that, what the chemotherapy response rate is in high grades. So,
but there are responders.
There are responders, but it's 10 to 15%. You know, and then in a recurrent setting, the most active agent is probably Doxil. But when you look at the control arm of GOG 281, which established trametinib as an option for these patients, the most active agent in the control arm, which could have been either the regimen of chemotherapies or the regimen of hormones, the most active agent was in fact letrozole. Yeah. So while it is active, it's still a hormonal disease, and I think it's a great point. We have to look at other hormones. One of the reasons why it's slower accrual, Dave, is because a lot of these patients were on hormone AI therapy. But SERDs is going to be the future.
All right, we are out of time, but I have people like giving me like these little sad puppy eyes that they really want to talk. So Ramos, go ahead, and then Bhavana.
Okay.
And then we have to turn it over to Dr. Herzog or to Tom after that.
Just a brief point that molecular testing is so relevant here.
Yes.
Because many patients are mislabeled as high grade when they're really low grade. And so this is an opportunity also for us to educate ourselves and our colleagues that molecular testing can inform therapeutic strategies, which can make a dramatic impact in clinical outcome. And I don't want us to also forget some of these patients are BRAF V600E mutation carriers. And there's combination dabrafenib and trametinib, which can be really efficacious for them. So it's just food for thought because it's an evolving and dynamic space.
And Bhavana?
I was going to say that.
Perfect.
GY19 is still enrolling.
Yes, it is.
Yes, it is.
But they're not BRCA for the most part.
Not.
All right,
that's
so
what-
we are going to turn it over. Thank all of you for your attention. Thank you so much, David.